of you a pleasant good morning and welcoming you to our meeting entitled Preparing the Health Systems for the Introduction of the COVID-19 Vaccine. We understand that this has been a very busy time for all of us, and I know for sure the immunization program managers, the expanded program and immunization managers have been extremely busy this month as we've been having several meetings around this topic. As you all may hear in the media, this topic is one of the top discussions. So for all of you, my name is Darlene Omir. I am the Family and Community Health Advisor for PAHO. I'm based in the Barbados office, but I work with Barbados and the Eastern Caribbean countries. And I am going to be your moderator and facilitator this morning because I'm going to do some sessions as well. So this meeting is organized with the objective of first updating you on the advancements towards the COVID-19 vaccine, and then also towards the COVID-19 vaccine global access, which is known as the COVAX, that some of you may have heard about before, and to provide a structured framework for the development of the country's national COVID-19 introduction plans. And finally, to offer you a structured framework for monitoring the readiness towards the receiving this vaccine. Each country has to be ready before they are able to receive the vaccines. As you know, this is a very highly valued product, and we need to ensure that when it's available, we are ready to receive it. So during the next hour and a half, we will be discussing around these precise topics. And the way we have it structured is that we're going to do 4 PowerPoint presentations. And then after this, we will be taking your questions and comments. So during the presentations, please take your notes, and you could also advance by putting your concerns in the chat box, because we will refer to this during the question and answers session at the end. So for now, I'm going to kindly request if you can keep your microphone muted. And I'm seeing at the moment, we have most of the countries connected. So I believe that we would be able to move on with our presentations. Our expectation at the end of this meeting is that all participants will be now knowledgeable on the development and the production of the COVID-19 vaccines, and that we are aware of the actions needed to be taken to be prepared for these vaccines in the countries. So to begin our meeting, I will ask Dr. Yitades Gebre to please do his welcoming remarks. Dr. Yitades Gebre is the PAHO WHO representative for Barbados and the Eastern Caribbean. And I'm going to note a slight amendment to the agenda. Dr. Gebre is going to give his opening remarks, and he's going to move right into his presentation related to the COVAX facility. So Dr. Gebre, please unmute your microphone and proceed. We're not hearing you.
Because it's not unmuted yet. Good morning. Thank you very much, Dr. Taylor. And good morning to you all, Chief Medical Officers, EPI Program Managers, other Ministries of Health officials, PAHO colleagues. Good morning and welcome, and thank you very much for being here this morning. As you all know, the vast majority of the population in our region and also globally remain at risk of COVID-19. The virus has the potential to do enormous harm and damage unless we take the necessary actions to stop the spread of the virus. We need to do all what we can do as governments and communities, civil society, and others to provide leadership, clear communication, and strong public health measures. It's very critical. Individuals need also to be participating in perspective. The public health measures which are needed so far has been to maintain physical distancing, clean hands frequently, wear masks where needed, and then where appropriate to improve ventilation and avoid crowds, close contacts, closed, poorly ventilated areas or rooms. That's not enough. This is the only thing what we have right now, but that will not continue for over the period of this pandemic. We need to have other tools. So effective vaccine diagnostics and therapeutics are very important, and then that will be vital for ending the pandemic, and then accelerating the response at country level, and then to have a better recovery from the economic downturn. But these life-saving tools will only be effective if they are available not only to the rich countries, but to the most vulnerable, equitably, and then simultaneously in all countries, in all locations. The pandemic so far, the pandemic is far from over. Last week, nearly 2.3 million new cases and nearly 40,000 deaths were recorded in general. The region of the Americas continue to have the 48% of cases and 55% of the death. At least United States, Brazil, Argentina are counting the greatest numbers of new cases and deaths in the region. So member states and territories who are participating in the COVAX facility, either as a self-procuring eligible via advanced market commitments, are strongly encouraged to use the tools which is available as a COVAX facility, which I will be discussing a little bit later. In the preparation, the issuance of COVID-19 vaccine to countries, the global reality, and then release mechanisms will evaluate the participating of member countries. That means that we have to be prepared once we have effective, efficient, and then safe vaccines. And then the use of this and then the deployment of these vaccines are very important. So this workshop, this seminar today, or the webinar, is definitely to have this dialogue, as Dr. Omer mentioned. Thank you, and back to you.
Thank you, Dr. Italis, for setting the stage for this discussion. As I mentioned earlier, we will now move, we'll make some amendment. We made an amendment to the agenda, and we're now moving to your presentation on the COVAX facility. We take note from the opening remarks from Dr. Gabriel that the pandemic is very, very active. He mentioned that approximately the Americas are accounting for 18,185,000 cases, and unfortunately 596,000 people have died so far. We're seeing your presentation now. Okay.
In the next few slides, I will be sharing with you about the issue related to the COVAX facility. As many of you know, we have this ACT accelerator. It's a mechanism which was organized or established by WHO and its partners to ensure the rapid and access to different technologies, especially for diagnostics, testing, and vaccines. In this regard, the ACT accelerator is a very important facilitation which brings governments, founding donors, co-host by WHO and the European Union, the European Commission. This list, which you are seeing right now, is the Facilitation Council, which includes, in particular, the Caribbean community. The Caribbean community is represented by St. Kitts and Nevis. The Honorable Prime Minister of St. Kitts and Nevis is the lead in health for the CARICOM Secretariat, the CARICOM member states. So that's why St. Kitts is part of this. So at least we have 10 regional groups which represent the whole global globe. And then we have the founding donors like Canada, France, Germany, Italy, and others, and then United Kingdom included. And as I mentioned, the non-governmental organizations also part of this are the Bill and Melinda Gates Foundation and the Wellcome Trust and World Economic Forum. The next one. So what is the goal of the COVAX facility? As I mentioned, there are three arms of the ACT accelerator. One is for diagnostics, to have a better diagnostic tests available, which will be rapidly, including the PCR testing and then antigen-based testing. So to accelerate the testing capacity in the countries. The second one is the therapeutics, and then to have effective and efficient treatment modalities to be available. We have at least 1,700 different modalities at this point in time to be tested and researched. And the third one is the vaccine, to have safe and effective vaccine. So for that, we have the COVAX facility, which is co-hosted by WHO, Gavi Alliance, and then CEPI. The goal is to support the largest actively managed portfolio of vaccine candidates globally to be available, and then having at least 2 billion doses by the end of 2021. So to offer also this a compelling return on investment for the countries by delivering COVID-19 vaccine as quickly as possible. As you know, as we speak, go back please, as we speak, we are losing on a daily basis the trillions of dollars from this economy due to COVID-19. So investment on vaccines would be also making to end in one way or the other this pandemic once we are able to find an effective and efficient vaccine. So the COVAX facility also guarantee fair and equitable access to COVID vaccines for all participants who will be part of the COVAX facility. To this end, the acute phase of the pandemic may be addressed by the end of 2021. So that is the goal of the COVAX facility. Next one, please. What is the focus at this point in time? There is a pool demand for the resources. That would be the participant countries, consolidated buying power, and provides participant access to a broader and actively managed portfolio. More than not only to focus on one vaccine from one site, but this COVAX facility provides a larger pool of vaccines which are in the different clinical trials when they are available. Therefore, there is on the right side the demand for the support, the availability, and they provide by the manufacturers to access a massive demand assured market. So that is what the facility will be doing. This is the first time in a century that the world has to come together to address a health crisis. Next one. So which countries would be participating? Currently, we have over 180 countries participating. But in this slide, what you can look is that those countries with advanced market economies who will be eligible as countries in low-income countries, lower middle-income countries, and then additionally, the IDA eligible countries from our sub-region like Dominica, St. Lucia, St. Vincent, the Grenadines are part of this process. I will just go directly to the next slide and then show more the availability on the vaccine at different stages. So additional vaccine support will be provided for those countries which are unable, due to their economy, unable to make payments through a donation. So vaccine access will be there. They will be financially supported for vaccines. There will be a purchasing mechanism, which we are using the PAHO revolving fund, and the delivery will be Also, countries will be also supported in the delivery through the support of cold chain equipment and technical assistance. As we speak today, tomorrow, there will be also additional webinar, if Dr. Omir has mentioned, it is about cold chain. So those of you participating as API managers, please note that we're gonna have another discussion tomorrow for the whole of the region. Therefore, it is an important mechanism for cost sharing, delivery, support to more than 92 countries which are unable due to their economies to make a payment directly. So there could be some little contribution. Overall, other countries would be also supported through this mechanism as donation. The next one. So there are three components of the formulation for vaccine strategy. This is a very important part of the COVAX facility. As you have heard, who would access vaccines once vaccines are available? My colleagues would also later on speak to you what kind of vaccines are available and where they are at this point in time in terms of the development in the research and development in the research. So once such an effective, efficient, safe vaccine is available, who gets them first? How it will be distributed? So the COVAX facility makes sure that there is an allocation framework. It sets a frame for overarching public health goals and priorities. That has to be based on the candidate independent mechanisms. The second one is that WHO has a strategic advisory group of experts, which is known as SAGE. They have been meeting for years and years for many other vaccines. So at this point in time, they also provide guidance on the policy advice. Remember, this is about policy advice in the context of specific candidate vaccines. Which vaccines are good for which kind of population? Is it for the elderly? Is it for young people? Or is it for people with chronic diseases? That kind of technical guidance would come from the SAGE. So the third one is the regulatory and the safety monitoring. We provide guidance on the regulatory issues, safety and monitoring, both for the candidate and the specific system-specific approaches. That means countries and the participant countries, our countries here, would have access to best information, guidance, vaccine strategy from the COVAX facility through these mechanisms. Therefore, participating in COVAX facility will benefit more countries. That's why we have now over 180 countries participating, and then almost all countries in the Eastern Caribbean are part of the COVAX facility. Next one. So what is the goal in the first one? The allocation framework is to reduce the COVID-19 morbidity and mortality. And the priorities in this context will be, since there will be a scarce supply of this vaccine, because we cannot produce 3 billion, 4 billion within 1 month or 2 months, as you know. So it will take some time to get the critical mass of these vaccines, which are effective and safe. Therefore, we have to start with prioritization of a specific population group for the vaccination. This could include healthcare workers like yourself, social care workers, older adults, others with high conditions, high risk settings, also consideration, specific policy recommendations from the SAGE based on product performance, because this has to come also once the clinical trials are progressing, and then some information coming out from there, the guidance and the policy would come. However, the basic priorities have been proposed, and then still countries are free to do and then make decisions whichever way they want to go. However, there is an overarching prioritization for specific population. So the first, the deliverables in terms of vaccine will be based on that notion and understanding. The timing is also very important. Given the ubiquitous nature of COVID-19, and initial allocation should be received by all countries, because we cannot just say country X have a lot of cases right now, we have to give to country X, and then country Y has no cases, we cannot provide. that's not the first doses would be. The first doses would be a ground, a floor for everybody. Equal amount of vaccines will be distributed from the COVAX facility. Eventually, and as time permits, based on the risk assessment of participants and vulnerability, the risk assessment of the countries, if we have more cases in country Y or country X, and the vulnerability of the certain population group, and then how COVID-19 is threatening that country, then the increase in doses or distribution would be considered as time goes by. The next one, please. So overall, the guidance at this point in time as a draft allocation framework and allocation mechanism for the vaccine for member state, based on the member state feedback. This has been going on in September, most of September, and early in October. The goal is to protect public health and minimize societal and economic impact, reducing COVID mortality. That is the first goal. In this result, we have the priorities: health and social care workers. All participant countries, your countries, have to get at least to cover 3% of their population to be part of that. This would be enough to cover all workers involved in the health and social care work. The next one is in the middle, high-risk adults. All participants receiving additional doses beyond the 3% to a total of 20% of their population in tranches could be considered as the next priority population to be considered. When I say next, it's not something first we deliver the 3% and go to the next one, but they are part of the first tranche of these deliverables, the delivery of the vaccines. The last one is further priority groups. Participant countries receive doses to the maximum of to cover 20% of their population. So if Barbados has 277,000 people, out of that, 20% of the population, which would be considered at the priority, they would have that 20% in the first deliverables. So the timing in this is the countries would be proportionally to their population, and their risk population, priority population will receive the first doses. And then if the outbreak continued, protracted, and severe supply constraints remain, timing may be also shifting for the different population. So there always, the facility would have a buffer set of for emergencies for deployment. So it's not just the 20% and then we just we say goodbye at that point in time, but based on the situation in the ground, some countries now facing enormous outbreaks and then decapacitating the health system and then many areas. Therefore, in that particular case, there is a buffer and then which could be also made available for emergencies. Next one, please. So the strategic advisory group, as I mentioned, the expert committee on immunization, also will introduce and set up certain criteria for the candidate vaccines, providing continuous review, and then providing guidance, policy advice, and providing guidance to ensure equitable access. Therefore, we will be guided by science, by the clinical trials, the evidence, when and how to make this using different models for prediction, which population, which age group, which gender would be more appropriate to receive the vaccine at different timelines of the development of the outbreak or the pandemic. So there will be a subgroup for vaccination goal and prioritization. There is evidence gathering group. There is also looking the vaccine impact. Once we have the vaccine and we started to do the vaccination, what happens? That also will be looked at. Next one, please. So there will be a value framework, the allocation and prioritization, This has already passed September the 14th. There is a guidance and prioritization of the target population, and then there is a policy recommendation. One important thing on the policy recommendation is that the regulatory approval process, which my other colleagues also will be discussing, so I will pass it on at this point in time. The next one, please. So there is no single vaccine which is guaranteed to succeed or has enough capacity. Again, what we needed is at least 2 billion doses by the end of 2021. Many vaccines are in development. None are guaranteed to succeed. No single manufacturer has the capacity to supply the globe, the volume we're talking about. Therefore, this is why we have the COVAX facility bringing together the diversifying the portfolio to diversify risk and create capacity to scale, to impact, to speed, scale, and access the vaccines. Next one. So here is the overall financial structure. I think just for your information, otherwise at the highest level, the chief medical officers, the ministers, the permanent secretaries have been briefed at many occasions. The COVAX facility cost principle is that we bring together the manufacturers and the countries to access vaccines. It is negotiation to achieve minimal returns in pricing, good pricing for the member states, the cost to be passed through the participation as is. There is no any middleman which makes middleman or middlewoman for that matter who may be benefiting or making profits out of this. There is full transparency. There is a choice for the participant and options, which most of our countries in the Eastern Caribbean went ahead and then to do the purchasing agreement and participant involvement in the facility governance. That's why now we have also the CARICOM for the Caribbean member states through the Honorable Prime Minister of St. Kitts being a part of this. So there are some costing which we put, there was some negotiation and the payment mechanisms with the manufacturers. All those have been discussed, so I will not go into the details at this point in time. Next one, please. So these are the two ways countries could access committed purchase agreement. Countries would have a lower down payment, which is about 20% of the total need they may have. They have to do a down payment, and then they have to sign a financial commitment that they will purchase the vaccines from this mechanism. So there will be a guarantee to purchase the doses, and then if they needed, let's say, 100,000 doses, how much that 100,000 will be guaranteed, and then they would pay for the down payment of the 100,000 doses at this point in time. We don't have the vaccine, but this is the mechanism at this point in time. So next one, please. For those of you who are very much interested to know, the upfront payment is already made available through certain mechanisms I will mention later on, and then how much it would have been was communicated to the countries. That process already is going very well for almost all countries in the Eastern Caribbean. So we don't have any challenges at this point in time to commit and then to look for the vaccines in the procurement and financial arrangements. Next one. So here is the target population, specific vaccination delivery approaches, and my colleagues will also elaborate here. The goal is to protect public health and minimize societal and economic impact by reducing COVID incidence. For that, we wanted to target first 20% of the population. The frontline workers, 3%, high-risk adults, 17%. So the delivery approach here would be there. I think our technical advisors would go into the details. However, the further priority, if needed, that would also cover additional priority population based on the guidance of the SAGE and others. So the buffer would be there for countries which may face an increased outbreak. Next one. So this is the vaccine availability. Just I wanted to touch base because both Darlene and Karen, Dr. Broom and Dr. Taylor will discuss about this. The availability of the vaccine projected to be in the first quarter 2021. The preparation must start now. So if we get the vaccine, let's say March, April next year, we cannot start to prepare ourselves in March and April. So it will be time lost. Therefore, we have to start to work in all aspects, the supply scenarios, the allocation framework, what countries have to do in the coordination, the supply logistics, and then the demand, what to do, what takes place at country level. And then there is a tool which my colleagues would also share with you about readiness and assessment, which has to start in the upcoming months until we have the vaccines shipped to the countries. So if you see this graph there, the review of allocation will be in February, and then later on in March, the shipment of the vaccine, April and May, or the second quarter of 2021, we may start to see vaccines coming at your doors. So that's why we are meeting today and then have this discussion. So I will stop here, and I thank you very much. My two colleagues and others would also elaborate more in this area, and then we will have more discussion. Thank you very much.
Thank you so much, Dr. Gebore. We take note of the COVAX facility being a mechanism in which over 180 countries have joined effort to do through the facility to purchase their vaccine via this agreement, and that most of the ECC countries are actually in the agreement, some by donations and some by actually making a payment. And of course, this will ensure then that once the vaccine is available, it would be equally proportionally distributed to all countries, as opposed to having the richer countries dealing with the provider and purchasing all, and then some countries don't get. So thank you so much for that insight on the COVAX facility. And now I am going to brief you quickly on where the development of the vaccine stands. And then because of the adjustment to the agenda, I'll just move in quickly to how some guidances as how we need to start preparing our COVID-19 vaccine introduction plans. So regarding the update of the COVID-19 vaccine, as we said earlier, that was, you could go to the next slide, please. As we mentioned earlier, despite all the public health measures, we won't be able to respond or curb this pandemic unless we have the complementary effort of the vaccine. So therefore, this is a key intervention that we're looking forward to. Now, usually a vaccine is a lengthy process to be developed, average 10 years. However, because of the pandemic and all the deaths that it's causing and the current situation, developers and experts have been doing an unprecedented speed developing this vaccine. And as of October 2, we have 42 candidate vaccines in the clinical evaluation stage and 151 candidates in the preclinical phase. Next slide, please. The next one, please. Yes. So this is quickly just to brief you on the phases, which most of us are familiar with. We have the preclinical that is usually done in animals, and then we have the phase 1, clinical trial 1. It depends, the variety has to do with the amount of people. And then in the clinical trial 3, we have specific groups we are targeting by age, by health, conditions, etc. And then the phase 3 is which we have a broader participants, and this is the phase that we now have 10 vaccines. And the phase 4 is what we continue doing all the time with all our vaccines to ensure we can monitor any adverse event. The next slide, please. So this is a quick review of how at the top of this slide, we are looking at what would be the traditional way of implementing developing vaccines, which is usually it had been done in a sequence. However, if you look at the bottom part of this slide, you can see that the COVID-19 has been doing the phases parallelly. So this would allow us to save time. But I have highlighted in yellow below in the slide that despite this new mechanism of developing the vaccine, the safety is still being in place and all the security measures are in place. So the fact that this is being developed in a much faster way does not subtract any safety issues from it. The rigorosity of the process remains the same. Next slide, please. So these are the 10 vaccines. If you, sorry, if you can see on the third column which countries they are being developed in. And we're saying, as I said earlier, we have 10 vaccines now in the clinical phase 3. And the means that is being discussed to apply this vaccine seems to be the intramuscular based on these 10 vaccines. And it seems like it's going to be a 2-dose vaccines, which most of the EPI managers will agree with me that it places an additional burden because we know the challenge in meeting the client 2 times to apply the second dose. The next slide, please. And this is just to summarize on what mechanism is being used: attenuated live virus, whole inactivated virus. The attenuated live virus is the one we use in the measles and rubella and the yellow fever. And the inactivated virus is what we use in the influenza and the hepatitis A. I think the new ones for us are the ones done with peptides, which is done with nucleic acid, and those are the ones that we don't have much experience with. But as I said, the quality and the monitoring is being in place for these vaccines. The next slide, please. So I just wanted to remind you that the fact that we have some vaccines in trial phase 3 and some are just in the preclinical phase does not mean that one is better than the other. It could well be that the vaccine reaching phase 3 would not be necessarily better than a vaccine that is now in phase 1 or phase 2. It's just the level of development that they are. The next slide, please. So you may ask yourself, why so many vaccines? I believe Dr. Gebre addressed this earlier. We don't know which one is going to be effective, so we need to be monitoring all of them. Based on previous experience, vaccines that go to preclinical trial, only 77% prove to be effective. And the different types may vary for the different populations. We might need a specific vaccine for elderly, we might need a specific vaccine for pregnant women, et cetera, et cetera. So then, hence we need to be monitoring all the development process of the vaccines. The next slide, please. Again, this would increase the chances of success, and it would allow us to predict which one will turn out to be viable, because we don't know that as yet. And also, as Dr. Gabriel mentioned, if we were only leading towards one, the possibility of one manufacturer producing those 2 billion doses would be very, very challenging, and would definitely limit our response to COVID-19 pandemic. The next slide, please. So this is just to remind you of the different mechanisms in place to ensure the safety and the technical coherence of the development of these vaccines. And as we mentioned earlier, there's an international experts team, and this is the RD blueprint, and there's several partners working to ensure that these vaccines are safe and effective. The next slide, please. There are many things we still don't know, but that necessarily has to limit our planning. We still don't know what the presentation might be. As I mentioned earlier, it seemed like it's going to be a 2-dose, and it would be applied intramuscularly. We don't know the cold chain requirements, and I won't go into details with that because we're having a meeting tomorrow. But it seems to be that we would require the same 2 to 8 what we are using now with our current vaccines. We don't know if it could be administered with other vaccines. We're still depending on research to get that information. And of course, we don't know if the same vaccine would be applied for children or adults. It might be a scenario where we would be having 3 vaccines applying simultaneously, one for elderly, one for adults, one for children. We don't know at this moment. The next slide, please. So to clarify, at this moment, we don't have any vaccine licensed, but we are monitoring all the vaccines that are being developed. And as per today, we have 10 in the phase 3 trial phase. So I'm going to, this would finish my presentation in terms of the update on the COVID-19 vaccine. I'm going to move quickly now into the preparation or the planning. What countries need to take into consideration to start planning for this vaccine. Now, as we saw the calendar earlier, we are thinking that we might have vaccine by the first quarter of next year. So we need to have several things in place to be able to respond and be ready to receive these vaccines. And I'm going to go quickly through some of the things we need to consider. And then my colleague Karen is going to go through the readiness that we need to ensure. So this guideline was shared with you when I shared the invitation to this meeting. And this is the PAHO guidelines that countries should follow, or it's encouraged to follow, in order to develop our country plans. The next slide, please. And the document looks at 2 areas. It looks at the technical components and the operational component. I'm going to go quickly on 2 of the technical components, and then we'll go into the operational components. And unfortunately, we won't be able to discuss each of these components, but I'm going to just share them with you so you could start thinking of how you need to get in place urgently to receive these vaccines. The next slide, please. So in terms of your vaccine objectives, so what do we want to achieve? What are our targets when we are responding to this pandemic? And as Dr. Gebre mentioned, we are looking to reduce the morbidity and the mortality, and we're trying to ensure reduce the transmission. And based on that objective, that's how we are going to identify which is going to be our target population. The next slide, please. So as I won't go much into detail in the target groups because Dr. Gabriel mentioned a bit about that. There's a whole framework that PAHO has developed, PAHO WHO, and how countries could go towards selecting their target groups. But we strongly encourage that health personnel and the older adults and people with chronic disease be in that first priority 20% group. And I think this is one of the main challenges that our plans are going to face, because most of our vaccine programs are targeted toward children. And the adult population, although many of us do apply influenza, we don't tend to measure the denominator. And at this point now, we need to start thinking, how are we going to reach to these older adults? How are we going to measure? Where are we going to register it? What strategies are we going to use? Are we going to sit at the clinics and have them come? Are we going to implement strategies? We need to partner maybe with the association of retired persons, maybe, to how we need to start thinking, how are we going to first know how many people we need to reach to, and then how are we going to reach them? The next slide, please. As I mentioned, we have a value frameworks that can guide you in how to prioritize in this population. The next slide, please. So first of all, we need to start thinking, do we need to update any policies in our countries for this vaccine? Do we have any importation amendments we need to make? Do we need to, I remember clearly with the HPV vaccine, some countries had to make some amendments to their policies because their policies had only addressed children. We need to ensure that our country has all the legal framework in place to receive the vaccines and all the documentation that you're going to need to get this vaccine in the country. The next slide, please. Then the organization and coordination. We're suggesting to establish a collaboratory COVID-19 vaccination group that would involve various sectors. As we saw, there are some countries that may consider to in their frontline workers, some tourism related workers. Then we probably need to involve that sector. How are we going to reach to these people? How are we going to reach back to them with the second dose? Should we need a second dose? And then this group would need to ensure also if we have to involve churches or community leaders or local governments based on how we define our strategy to reach to these groups. The next slide, please. The cold chain management, are we able to receive them? This vaccine is I mean, all vaccines are precious, but we don't want experiences of when vaccines had been sitting on the airports for 2 weeks. We learned about that 2 weeks ago, one of the countries. So we need to ensure that our flow from to the storage is in place. Do our storage capacity, do we have the capacity or space enough to cater for these additional vaccines? Do we need to start buying more refrigerators? Do we need all of these issues? And we're discussing the issue about security, because it was raised in one of the meetings as well, that where we store these vaccines need to be well secure because of the preciousness of these vaccines. There might be some risk of we losing some of this vaccine or them being stolen. The next one, please. And then, of course, the whole issue of safety and surveillance. And I know many of us, we had a workshop on this yesterday, so I'm going to pass through this quickly and I'll go to the other one. And the monitoring, again, the coverage. How do we measure coverage for the tourism health sector, for example? How do we measure coverage for people with chronic disease? That denominator, we need to get the denominator data, because if we don't have that, we won't be able to report on the coverage. Then we also need to monitor the acceptability and, of course, the ESAVI. The next slide, please. The delivery, I think this is one of the basic challenges, because we still need to continue our delivery, ensuring infection prevention and control and applying our public health measures. But now we need to think out the box in terms of the strategies. How are we going to reach to these groups? And I think one of the things I want to highlight here, and we saw this with the experience with the HPV vaccines, that unfortunately everyone would not be able to receive the vaccine in the first stages of this. And hence we might have challenges in some people understanding that you can receive the vaccine, but your sister can't or your child can't, because they are not in our priority group at the moment. So we need to ensure that we could communicate this effectively to the population and how people could understand why we're selecting some people and not others. Even within one household, it might well be that me as a health worker, I can receive it, but maybe some of my other relatives that lives in the same household with me would not be able. So this discussion needs to happen within the country. The next slide, please. And of course, the training, we have to have a training plan. We need to make sure we identify who is going to be our training of trainers and how we're going to roll out this training in a fast and effective way. I know in some cases, some countries, we did a video with the training and then we were having that video shared to the health facility. We need to start thinking how we are going to roll out this training in an effective way. The next slide, please. The guidance also talks about the communication and information. As I was saying, we need to communicate effectively to the countries, because the fact that some people will get it and some won't has to be clearly shared as to why. We need to start defining what those key messages are going to be and how we're going to spread these key messages. We need to start developing the materials that we're going to use if we're going to, if we're going to use health authorities involved in giving the messages. Are we going to use videos? Are we going to use TV? We need to start developing all these messages. And for this, PAHO is also developing some samples that countries can use to adapt to their reality. The next slide, please. Again, the same issue about communication. We need to ensure vaccine trust, and we also need to ensure vaccine confidence. The next slide, please. Oh, this is just to highlight to you that there was a survey done in July by Bill and Melinda Gates, just to have an idea of how population are thinking towards the vaccine. And we have a lot of people concerned about the safety. So we need to ensure that we could deal our communication strategy to address this. As you heard, the safety procedures are always in place for vaccines. WHO would not certify a vaccine if it hasn't gone through a rigorous process of monitoring and evaluation. And then there's also some people that felt that the vaccines were not, they didn't have a positive feelings toward it. So we need to ensure we can address that. And the good thing was that most of the people 55 or older were very enthusiastic toward the vaccine. The next slide, please. And then our information system, how are we going to register these vaccines? If we have an electronic information system, do we need to make adjustment in the systems? Are we going to use a paper base? How are we going to ensure that this is, all this thinking of how we're going to start registering and how we could ensure data quality in the registering and the application of these vaccines. And I think this is my last slide, which is the next steps. Sorry. The next step then would be for us to start developing our plans based on all these considerations I gave you and the document I sent. Then you need to assess your needs and then reach out to us to see how we can help you with some of your needs. If the need has to do with training, if it has to do with something in terms of the cold chain, or if it has to do with repeating this workshop or whatever, please let us know what your needs are so we could help you. You need to establish a working group with the members that I suggested earlier in the slide to start preparing these plans. And then we're suggesting after this meeting to do bilateral technical support. And the next slide, I'm just suggesting some dates. As you can see here, we are proposing that by the end of November, countries would have a draft plan. As you heard, we're thinking on the first quarter of next year. So we need to ensure that we have plans in place for this vaccine. And on this calendar, I'm going to share with you also, because I'm also going to share the presentation. And this is our proposal for the bilateral sessions with the country, what takes us right up to December 1st. And this is not meaning that we would only do one, but this would be the first one. It might well be that we might need to come back bilaterally to the countries. So with this, I'm finishing my presentation on the plans, and I'm going to hand over now to Dr. Broom. Dr. Broom is our advisor for immunization for the Caribbean, and Dr. Broom will be sharing with us now the requirements needed to ensure that you are ready to receive the vaccine, because, and she's going to reinforce this, your country will not receive your vaccine if you are not deemed you're ready to accept these vaccines. So over, Dr. Broom, please unmute your microphone and proceed.
Thank you so much, Darlene, and good morning to everyone. As Darlene has said, I am here to speak about COVID-19 vaccine introduction, the readiness assessment tool. So all of you would have already have received the assessment tool. It is an Excel spreadsheet that I have found very, very, very useful at a country level. Can I have the next slide? So here we have, it is a national tool, and you would see that it has 5 tabs and 10 areas. Throughout the presentations this morning, you would have heard about assessing countries' readiness to accept the COVID-19 vaccine. And I want to emphasize this, that manufacturers and Gavi and COVAX are going to be very concerned about sending COVID-19 vaccine to a country that they believe have not met all of the preparation criteria, all of the activities that are determined that are required to be able to accept the vaccine and implement your plan to distribute and administer the vaccine. So it's really very important that if you haven't started at this point, that you put pen to paper and get those plans going. The tool will really help with this. All of the activities that you need to do are here in this tool, including those pre-preparedness activities that I'm going to speak a bit about. So the tool has 5 tabs. The first one is the general indications for use, and that just is an introduction to the tool and tells you all about the tool. And the only place you need to put data in the tool is the National Readiness tab. This sheet is the one you need to put the data in, and the others, which are the dashboards, that is just where the data is displayed in charts and graphs that are really good for you to be able to get a snapshot of where your country is. So I'm going to go ahead now and just talk about the sheet that is national readiness. So we have 10 areas that the tool talks about in terms of getting your country ready for the introduction. And if we look at these areas, you see there are 10 areas, and we're all familiar with these areas. There's nothing new. We have used all of these areas when we have introduced other vaccines. It's just that the COVID-19 vaccine has some very specific requirements that we would not have had to really think about or needed guidance on before. If you look at these vaccine areas, you will see that Darlene went through all of these areas when she spoke about the plan. And that's why I'm so excited about this tool, because just by following this tool and doing the activities in this tool, you are really putting all the activities that should be in your plan. You are conducting these activities. So next slide. All right, so this is the national readiness sheet. I just took a snapshot of the planning and coordination, and you can see that it gives you timelines, it gives you the pre-planning activities, and those pre-planning activities, they say they're red, but to me they look sort of pinkish. And then you have your activities and your recommended timelines to get these activities done. The pre-planning activities really should have been conducted in September. And these come with a tick box. So when you've done these activities, you tick them off in the tick box that you see here in the pre-planning activity column. And you also have the dates at the top that you put in. So let's say that on September the 30th, you looked at all of your pre-planning activities and all the other activities, and you therefore said either you completed the activity, it was in progress, or it was not completed. You put the date at the top to determine when you made that review. So if we look here at the pre-planning activities, we will see in planning and coordination, it is the same National Coordinating Committee that Darlene spoke about when she spoke about what was needed for the plan. And I want to emphasize that this committee has to be intersectoral, wide-ranging, private sector, public sector, civil society, because the introduction of this vaccine will entail all of the efforts from these groups, whether it be tourism, finance, civil society in terms of some NGOs. The coordinating group is going to be quite wide. And then you have your technical working group, which are those are the technical persons who will be looking at the guidelines, who will be making decisions and receiving reports from your subcommittees. I know that the tool, if you look at the first activity there in white, these are a lot of subcommittees. And let's be realistic, in the Caribbean, our islands are small. And a lot of times the same people are doing the same things. The same people are required to do all of these things. But as much as possible, try to get your subcommittees together. If the committees have to be looking at more than one area, well, do that, because I know that our human resources are finite, and we need to find a way to get the actions done. So For the coordinating committee and the technical working group, it is important that you have your terms of reference for both of these and that you have your regular meetings so that you can oversee and supervise and monitor the implementation activities. Next slide, please. So here we look, we see that looking at the existence of regulatory pathways of approval for the COVID-19 vaccine are very important. Darlene spoke about this, but here you have to notify PAHO about any of these pathways because it is important that you are sure that these pathways have been elucidated and are clear so that when it is time for the vaccine to arrive, that there aren't any hiccups, any problems with the documentation, any problems with the communication of the various agencies. So you have to have the timelines, the number of days that you would expect this pathway for approval to occur. So that's your regulatory, and that's the pre-planning, and then you have your activities after that. So you're identifying your documents, you're confirming with WHO, and you're ensuring a system to waive any procedures or testing that needs to be waived. Looking at the prioritization, targeting, and COVID-19 surveillance, the pre-planning activity here is monitoring the progress of NITAG working groups. And I want to speak about this. In the Caribbean, we are small, so we don't have national technical advisory groups as a rule. We have our CITAG, which is the Caribbean Technical Advisory Group. And this group works on behalf of the Caribbean. And the recommendations that come down from PAHO, WHO, they also look at these recommendations. And if there needs to be some amendments or clarification for the Caribbean region, then they do that. So we have a CITAG. Next slide. All right, so in terms of service delivery, we heard Darlene speak about the importance of having your protocols for infection prevention and control. If we are delivering a service, that means we're interacting with the public. So we must have our protocols for the adequate PPE for staff and to also speak about what would the environment be like when we are administering these vaccines. It's not just about administering vaccines in the clinic. It may be that you have different strategies to administer these vaccines. And wherever you do it, you have to make sure that your protocols are in place. Some persons might stick with the clinics. Others might decide that they're doing a drive-through. Others might decide that they're going to use pharmacies. Others might decide they're going to use private doctors in the private sector. But wherever it is, the protocols for the infection control must be there. Training, again, you have to have your training plan. And with your training plan, it is about what are we training on? We don't necessarily know exactly the method of administration for the vaccine. We don't necessarily know what temperature the vaccine is to be kept at, but we know the things that we need to train on. So our training plan can focus on that. We know the persons we need to train. Therefore, we look at the training groups and we look at who are the best trainers that we can employ and have your training plan done. Next slide. Monitoring and evaluation. This is extremely important. It is not only that we have to monitor the coverage, we have to monitor if there are any adverse events. We need to continue monitoring disease surveillance. So that means we need to continue saying how many people have actually been infected and have COVID-19. So along with the vaccine administration, we have to continue our disease surveillance. I want to emphasize something that Darlene said. In order for us to accurately measure our coverage, we need to know what our denominator is. If we decide that we are immunizing persons who are over 65, how many people do we have in our population? If we're deciding we are immunizing those with comorbidities, how many do we have? We may not be able to get those figures from health. We may need to go to our national statistical unit. We may need to go to our tourism sector if we need doing tourism workers. We may need to go to our private sector bodies such as our nursing association or our doctor association to find out the denominator for our healthcare workers. But this is one of the pre-planning things that we need to do because it should have been done in September, so we have to make it a priority at this point. Vaccine cold chain and logistics, I'm not going to go into that because we have a good session planned for tomorrow. Next slide. So lastly, we're looking at the safety surveillance, and we would have had a session on the adverse events that may or may not be related to vaccines. But with COVID-19 vaccine, this is extremely important. This is a new vaccine, and we have to have a strong platform for recognizing and identifying any reaction that may be related to the vaccine, any reaction to investigate any reaction that we think may be related to the vaccine, and also then to do our communication. Because heaven forbid that we do all of this work to implement the vaccine, and we have someone who, by the way, may have had a reaction to the egg that they had for breakfast the morning, and then they come and get the vaccine, and it seems as if it's a vaccine reaction, and we have the demand for the vaccine falling. We must have risk communication, and we must have it done before implementing the vaccine so that we have our messages ready for if there may be any adverse reaction, vaccine related or not, that we have it and we're ready to go to not only to the public, but to our staff, to our stakeholders, so that we don't have our vaccine plan derailed. Demand generation. We can't sit back and believe that the COVID vaccine is here, so people are going to come for it. We have to generate demand. In order to generate demand, it calls for advocacy. Identify your vaccine champions from now. Who does the public trust? Who is going to go out there and say, COVID vaccine is coming, it is going to be safe, it is going to be effective, and we need to have these groups immunized. We need that social mobilization. We need that community engagement. And it won't just come by snapping our fingers. We need the training to do it. So that is why this is one of the pre-planning activities that needs to be implemented as soon as possible. Next slide, please. So just quickly here to say that we see the optimal timeframes for each of the activities, and you are required to put information in the boxes that are shaded yellow. So as I said before, either the activity is completed in that specific timeline when you do your review, it is in progress, or it has not been completed or not started. Next slide. So this is an example of the activity dashboard. Now, this dashboard is just a graphical illustration of what you have achieved per that time interval. So here we look at an example of what was achieved by the end of September. And we see here that 6% of the pre-planning activities were achieved. They were completed, 7% are in progress, and 87% the country put no response for that. This activity dashboard will show you all of the activities for the proposed timeline. So all of the activities that were supposed to be done in September, this is what we're going to see. But the other timelines, which were October to November, December to January, February to March, we're going to see those same activities and the same graphic here when you look at your activity dashboard. You're not required to put any data in here. This data is pulled from the previous tab, your country readiness tab. Next slide, please. So here is the areas dashboard. This is the next tab. So this is tab 4, sorry. This is tab 4. And what this area dashboard does is it looks at each area. So in the planning and coordination area, we see that for September, we had 50% of the activities in progress and 50% completed by September. All right. So for each area, you can go into the areas dashboard and look at what have I completed in this area? What is outstanding? Or it may be, I have completed everything in this area. I can now focus on something to do with logistics, something to do with regulation. So the areas dashboard, the activities dashboard are a good tool to just see at a snapshot where you are either with your timelines or with your areas. Next slide, please. So the last tab shows you your reference page. I love this page because even when I'm not dealing with the tool or not looking at areas in the tool, I am looking at this reference page because it contains a list of the planning and technical documents. I don't have to go and search. All of the documents are here at my fingertips, and I can access them and look for the guidance as necessary. So yes, using the tool, yes, doing your plan, this tab is excellent for having the documents to provide you with the guidance, having the documents for you to refer to really detail your plan and make sure it has all of the activities required. Next slide. So in summary, this is a national tool. It is a tool to be used by each country. We spoke a lot about assessing country readiness and about using this tool to assess country readiness. You use it to assess your own readiness, but there is some discussion about it being used outside of the country at a regional level or at an international level to determine country readiness when vaccines become available. The tool details activities to be conducted, and it has the dashboards which show you the activities via the timeline and also each area, the snapshot, what is my progress in each area, not just in terms of the toolkit, but it can also correspond in terms to your national COVID-19 vaccine implementation plan. And again, the reference page is a great resource for planning and technical documents. Next slide. So that's it from me. Thank you very much. And I am here for any questions that you may have, along with the rest of the presenters.
Thank you so much, Dr. Broom. We take note about this important tool that would aid us in seeing our advancement and our readiness, and particularly the note about us probably using it as a reference as a region to see how many countries are ready and how many are not, since this is an important criteria to determine which countries can receive the vaccines or not. Okay, so following our agenda now, we will now take any questions, any concerns. Let me see, I'm seeing something in the chat box. No, I don't see any questions. Are you seeing anything, Brenda? No, I'm not seeing any questions.
No, I'm not.
No. Does anybody have any questions, concerns?
Good morning.
Good morning.
Dr. Celie Thomas Antigua,
Good morning,
Medical
Dr.
Officer.
Hi.
Good morning. Thanks for this presentation. Very informative to prepare us for COVID-19 vaccine. I noticed that you mentioned, I think either you, Dr. Taylor, or Dr. Boom, the need for a national committee and another technical committee. While a lot of us will have national immunization committees, are there specific terms of reference and suggested composition of those committees that you could share with us? That's the first question. The second thing is also, do you have like a template for the plan and the plan that we're supposed to develop? And thirdly, I heard you mention the fact that if countries are not ready, are deemed to be not ready based on an assessment, they won't have access to the vaccine, and that's understandable. And I'm sure all countries would be ready, including Antigua and Barbados. But I just wondered, before we actually were asked to participate during the preparatory phase and before payment, was that explicitly stated to countries? I don't recall hearing that before. And if a situation arises where a country is deemed to be not ready, would the funds be refunded? Thanks. The down payment. Thanks.
Okay, Karen, can I take the one on the template and then you take the one on the committee?
Go ahead.
I'm going to ask Dr. Gabriel to take the one on the payments. Regarding the template, so we don't have a template. And precisely yesterday, we were discussing with Dr. Gabriel that we probably need to design one similar like we do with the Vaccination Week of the Americas, which we give a template to ensure all the components are there. So we're going to be working on that to share that. I think that would make things much, much easier. But the only thing we wouldn't want you to wait on the template to start some of the thinkings and things, but what I know. So we're working to provide a template. Yes, we are. And then regarding the committee, as Dr. Broom said, there are so many committees in the countries, and we have our National Immunization Committee. I think the main thing, once you read the guidance, is that this committee might not have the usual people that we have in our national committee, as we were saying, members of the retired associations, etc. And I think that's what makes this unique. So it could well be that you decide that your National Immunization Committee would just integrate some other members to respond to the specific needs of the COVID-19. I'm not sure, Dr. Broom, if you want to add something on that.
Not on the committee specifically, but just to say that PAHO does have guidelines on implementation of vaccine. I can share them with Darlene so that she can share them with the countries, or I can share them with the countries. And it is the same activities. It's the same general framework, but that is, and the guidance talks about what you need in each section, so that I can share that so that the countries can have that and work with that. I want to say that in terms of your last question, in terms of if the country isn't ready, I do not foresee any of our countries not being ready. but I agree, you need to ask the question. To me, it is about if the first tranche is there and the country, and it's not going to be, oh, the country isn't ready, so we're not going to send the vaccine. It may be, oh, we didn't see the training plan, oh, we didn't see, so the country would say, oh, yes, but we have it here. And so to me, it is not a blanket statement of not ready. It is more about, we would like to see, or has this been put in place and the country confirms. So I think that's where that is really. Especially PAHO is all about assisting countries and guiding and making sure that all of the countries have all of the activities in place. And as Darlene said, so those meetings with the countries are critical to ensure that all of those components are there and that everyone is ready come January 1st.
Thank
Yeah.
you.
Thank you. I'm not sure if Dr. Gebre is there, if you want to address the question on refund, but oh yes, there he is. Dr. Gebre, I'm not sure if you heard Dr. Ronda's question. Okay, okay, okay.
Yes, in full. Thank you, CMO. Actually, Dr. Broom illustrated very clearly. We anticipate all countries to be ready, but when it comes to the readiness, this is also our responsibility from PAHO to make sure to make countries ready. That's why this meeting is all about. Therefore, I don't have any reservations or doubts that the countries will be ready by next October, by next March or April. Such doses will be available, and if the dose will be shipped. If the countries, for certain reasons, just God forbid, if there is a bad hurricane, and then even though we are almost out of the hurricane, just an example, the health facilities were not able to make the cold chain ready or something like that. We may delay those kind of with understanding. Otherwise, with the checklist, we cannot say that the country is not ready and then not ship the vaccines. On the other hand, we have this commitment agreement which is signed with Gavi, and there will be also a commitment agreement to be signed between PAHO and the countries about the transferring of the funds. PAHO will be transferring the funds to Gavi through any mechanism we have. So the agreement would be with Gavi, and then whatever we have signed with Gavi, countries have signed, that would be the most important tool, legal document you may have. I again reassure you that the countries will be ready. We are here to support you to be ready. Back to you.
Thank you. Do we have any other questions?
Hello, good morning.
Yes, please.
Yes, this is Mr. Atel Alfred, that is from Antigua, Director of Pharmaceutical Services. I just wanted to piggyback on the question of readiness. Now, one of my concerns as it relates to that is the fact that, one, we don't know exactly where we're going in terms of the final products as yet. And I see that there is a possibility that there might be some extreme storage conditions for the vaccines. Now, the regular storage facilities that countries have at this point might not be able to facilitate that. Is there anything in train or anything in place, one, for the assistance, and two, for the guidance as to what those storage facilities might be relative to costs so that countries can prepare themselves? Over.
Thank you, Mr. Alfred. Yes. So I'm going to go a bit ahead of the meeting tomorrow, but tomorrow it would be very, very good if you could participate in that meeting specific for cold chain management. As you saw in my slide, 2 of the vaccines seem like of the 10 that are in phase 3 might require different temperature. The other 8 will use the same, seems to use the same minus 2 to 8 centigrades. Sorry about that. So yes, PAHO is definitely willing to provide assistance in this. And I think that's one of the main objectives in the agenda tomorrow, to specifically give you some guidance on what you need to have in place, and also to see what you need and to see how best PAHO could support this. Because as you well said, there's many things we don't know, but there are things that we do know. And we do know that what is our current capacity to store vaccines? Do we need more? I'm not sure, Karen, you're saying you want to add something to that as well? No? Okay. Yes.
May I add?
Sure.
Earlier in the COVAX facility presentation, especially the 4 countries in our Eastern Caribbean, St. Lucia, St. Vincent, Grenada, and Dominica, do have additional support in the countries to access for cold chain of that related preparation, not only for the vaccines. That's in addition what we are discussing. As Dr. Taylor also mentioned, let's have first the so-called assessment, look at the assessment tool, look at your preparation, and then identify gaps. So where could we mobilize resources? We need as much as $38 billion for the COVAX facility, and then we are now short $14 billion. There are so many other financial institutions are coming and knocking the doors, either to provide some assistance or different mechanisms to make resources available. Yes, we're going to look into this, and including from PAHO. We are not saying that we're going to buy everything needed, but we should be looking into mobilizing some resources. Back to you.
Thank you. Thank you very much. Any other questions?
Yes, there's a question in the chat. Explain the difference between clinical and preclinical phases.
Okay.
Unmute your mic, please.
Sorry. So on my second slide, I actually had that there. The preclinical is when we do the trials in non-humans, and the clinicals is when we move toward humans. Over. Any other question in the chat, Brenda?
No question, but Joycelyn Walter Thomas, she has her hand up.
Okay, please go ahead.
Hello, good morning, everyone, and thank you again for these very timely presentations. I do have one concern, and it's about the time frame for generating demand, and I'm going to add there and generating trust as well. From our experience with the implementation of the HPV vaccine, one of the biggest hurdles we had was to convince the healthcare workers, not just the population, but the administrators themselves, that this vaccine not only is coming, but it is safe. And I'm just wondering, how soon would we be able to get a communication strategy together so that we can be ready in that regard? Because that's going to be a huge component of how persons are going to respond to this vaccine once we're able to get our hands on it. Over.
Thank you. I'm going to go first, and then Karen, you can complement. But one of the purpose of that study that was done in July this year was precisely to have a feeling of what people were thinking. There's also another study done in September in terms of web search to see what people were asking regarding the vaccines. And there's it's balance in terms of the credibility or not. But I do agree with you that the health workers are the key persons to be, because they would be the ones actually training and conveying the message. And that might be the group we need to work with first. Now, in terms of developing this communication strategy, we need to have that similar information in country. And as Dr. Broom was saying, to see who would be our champions and who could help us. Now, we could, PAHO is developing some communication materials, but the communication strategy has to be specific to the country. The country has to develop their communication strategy based on their specific needs of information in the country. Karen, you want to add something to that?
No, just to add that I agree with you. The healthcare workers you have to get them on board, because if you don't get them on board, and we saw this a lot with HPV, that your whole plan and implementation can be derailed. Therefore, the data that would be the data such as the safety data, that can be shared, explained to the healthcare workers so they understand that the vaccine, number one, is safe. And then you would still have your efficacy data, because that will also be there as well. So those two things can be used to that technical group, because some of them will understand those technical things. But the other thing is that there has to be a champion, and those those managers have to lead by example. So, however, you have to show that you have the trust in the vaccine. You have to show that you know about the safety data, you believe in the safety data, and you believe in the efficacy and the rigorous, what is the word I'm looking for when I'm talking about the guidelines, the regulations, all that WHO has done, and there are independent bodies that also look at that data. So those are the things you have to arm yourself with in going to your healthcare workers, and then also your champions in going to the public.
May I add one thing on this?
Sure.
I have posted on the chat a link from WHO. This is about the a training on a call for application for training in the infodemic management. So this training will take place November 3rd to the 27th. It's for national authorities and UN staff and others who are very much interested to build up their capacity in counter this kind of anti-vax or whatever you may call them, to have a better grasp on it. Yes, we are also fighting at this point in time, not only with the pandemic, but also infodemic, which are affecting our work. So please look into this and then have a greater participation at the country level as well. Thank you.
Thanks. Okay, any other questions?
Well, there is somebody saying that she's not still very convinced about it. I don't know what was the, oh, okay, about the clinical and go back. Look at the chat.
Let's see. It's not. Oh, this is Florestine. Florestine, were you asking the question about the difference between the preclinical and the clinical?
Yes, that was her.
Okay, so I can't pull up that slide now again, but basically when we do the preclinical trials, they are done in animals. And that's when, that's probably the first, if I could go back to that slide, but that's the first. Preclinical is when we're doing it at that level. Once we move to humans, we call it the clinical trials, and that has different stages. It has 3 stages, 1, 2, and 3. The stage, and the difference is based on the amount of people involved. For example, in stage 3, which we have the 10 developers at the moment, they were using a broad universe of people being tested or being, I'm not sure what the correct word there would be, being vaccinated to try the vaccine in the trial. That's the word. A broader group in the trial. In the phase 2, we're looking at target groups. We look at children, adult people with chronic disease. And then the phase 4 is the phase that we are continuously on. Like we're in phase 4 with all vaccines, because it's the continuing monitoring of different ESAVIs that may come. I'm not sure if that's a bit better. If not, you can unmute your microphone. I know Florestine is communicating from Dominica, EPI Manager Dominica.
I'm okay, Dr. Darlene, I'm fine. I'm okay with your explanation. I have so many concerns as it relates to the COVID-19 vaccine itself. You know, there are so many things going wrong in terms of the efficacy, in terms of the side effects, the mere fact that it is a new vaccine. I have a lot of uncertainties, and I know my public will give me a lot of resistance, and I am not convinced to be able to explain to them. So that's my challenge. I'm being honest. Thank you.
Thank you, Florestine. I just wanted to pull back on something Karen said earlier, and I think I said it also. The vaccines that we are currently using were approved by the same body that is monitoring and will approve the COVID-19 vaccines. And if you recall in my slide, the area highlighted in yellow, the technical requirement, procedures, and rigorosity are in place with COVID-19 as with all vaccines. WHO would never approve a vaccine that they don't deem safe for the public. You wanted to say something, PWR? I'm seeing your microphone on, yeah.
Oh, okay, so I'm muted. Well, I think the Ms. Nurse Lewis or Ms. Lewis from earlier comments and worries. First of all, we don't have any COVID vaccine at this point in time. As Dr. Taylor mentioned, whatever we have, these 200 different stages, preclinical and clinical, the three phases, including 3A and 3B, at different stages we have. Out of that, there are at least 9 promising, which are in the clinical phase. So once we have finished and then we move into production, more information would come, more publication on this the development, then we can have discussion about what kind of vaccine for who, and then when, how many doses, and then all those kind of things. We are now preparing when and, well, I shouldn't say if, but the situation is that if and when COVID vaccine is available, how are we to prepare ourselves to make sure such a vaccine would be rolling out in our health system? To end the pandemic, the best tool we have would be to have is the vaccine. However, until at such time, that was what I was trying to communicate in my earlier opening remarks. We continue the physical distancing, infection prevention, etc., which has worked. That was to reduce the surge in the health facilities. We are saving the health facilities, saving healthcare workers by making those things available. Now, to save the economy, to save humans in general, we have to end this pandemic. What is the exit strategy? The exit strategy is that to have a better testing capacity, to have better medicines, and for sure to have vaccines, which is preventing morbidity, mortality, and transmission. That's where we are at. So we don't have a vaccine which is now, which we can fight about whether it is working, and then the public is saying, we don't have that one. Once we have that information, we're gonna start to work on this clearly. This vaccine is much better for an adult or with chronic diseases. This better for young people, whichever risk factors they may have. So that is the time you will be discussing. And then in the meantime, we don't have to confuse ourselves and also confuse in general for the vaccine, which we don't have at hand. Back to you. By the way, I want to add also, when you say clinical and preclinical, as Dr. Taylor mentioned, it is in animals. All the challenges would be taking place in animals for efficacy and safety. The second one would be clinical in humans. So at that point in time, there are certain end outcomes we're going to look at. Only 7% of the vaccines actually succeed from preclinical to move to clinical. And then only 20% of the vaccines which are in preclinical may be successful and have the chance to succeed. Therefore, we are far away from a vaccine which is to be available for public consumption at this point in time. But we are working, we have faith in the evidence and the science. Back to you.
So do we have any more questions?
No more questions in the chat.
More question in chat? No more question?
One, I would just want to raise one last point from where I said, again, Alfred Attil from Antigua.
Yes.
The issue of costs relative to transportation, freight inclusive, that is something I think I saw a timeline as it relates to dialoguing with the different countries. So that is something that I would want to raise when the discussion starts with Antigua, because I think if we're going to be looking at the resources and maximizing the financial resources, that is something that needs to be addressed. Okay.
Okay. Noted. Anybody else? Okay. It seems like we don't have any more questions. So with that, I would like to then close this meeting. First of all, thanking you all for your participation, and to convey the next steps, just to remind you again, is for you to start developing your preparation plans. And for this, with the proposed agenda I shared earlier, we, Karen and I would be reaching out to you, to your countries, and then we would start addressing some of the issues as what Mr. Alfred said and others that may come up. And be assured that any new information we get, we will be sharing as well. And again, to reinforce that PAHO is here to support you on this, and that you can reach out to us at any time. Karen, do you want to share some closing remarks on your side? You have anything else you wanted to wrap up there with?
Just to say that I think this has been a very good session. Please remember, if you have any questions, any concerns, any clarifications needed, do not hesitate to reach out to Darlene or myself, so that we can ensure that you're proceeding with your plans, with your pre-planning activities, and that we are here to assist you. And I'm seeing here that Brenda has put that the presentations will be available. So that's very important. You can always go back and reference the presentations. So again, thank you so much for participating. And it would be really great to see all of you tomorrow in our meeting on the cold chain and logistics.
PWR? You wanted
Okay,
to...
thank you very much, all. Thank you, Darlene, Dr. Broom, as well, all the CMOs who joined us, and the Ministry of Health officials. We'll be very much encouraged to have another dialogue on this. This is the start of a series which Dr. Omir mentioned in her remarks earlier. Thank you very much for considering to be here this morning, for your commitment. Be safe, be strong. Yes, we can beat COVID-19 with the appropriate tools, including vaccines.